Assalamualaikum warahmatullahi wabarakatuh. A very good morning. My name is Ahmad Hatim Sulaiman, psychiatrist from Department of Psychological Medicine, Faculty of Medicine, University Malaya. So I'll be moderating the second session for today. So we are very fortunate to have Dr. Fatin Liyana binti Azhar, who is a child and adolescent psychiatrist. She has joined the psychiatry child and adolescent unit at University Medical Center since 2019. So very experienced child and adolescent psychiatrist. She did her undergraduate training at University Putra Malaysia and postgraduate training at University Malaya. So her work mainly and research mainly focus more on child and adolescent with ADHD, attention deficit hyperactive disorder, and children with major depressive disorder. So today, Dr. Fatin will be talking or presenting on childhood mental health disorder, parental factors associated with child and adolescent medication adherence. So without further ado, let's welcome Dr. Fatin to give a presentation.
Assalamualaikum. Good morning, everyone. To my UMHealth colleagues. So let me just share my screen. So for today, I'll be given the opportunity to share with you all. The title of my topic for today is Childhood Mental Health Disorders, the parental factors that are associated with child and adolescent medication adherence. Okay, so my talk today will consist of two parts. Firstly, I will briefly explain the types and the examples of the childhood mental health disorders, especially the common ones that we encounter here in our clinical settings. And also the second part will be the challenges in our management, whereby namely we are faced with a lot of the parental factors associated with medication adherence in our child patients. So this will be the overview of the lecture. Firstly, I'll briefly talk about what is childhood mental health disorder. And because it's uniquely presented in children compared to adults, so we'll be talking also about factors that influence the behaviors and the type of behavior problems presented in children. And we go on to the common childhood mental health disorders. I'll briefly explain on some of the common types and also other common behavior disorders. We go a little bit on the management and the challenges, and finally to the parental factors. So firstly, so what is a childhood mental health disorder? Just a brief for this definition. So it is the abnormality and the difficulties of the emotions, the behavior, academics, and relationships, sufficiently severe and persistent, okay, because it's a disorder. So causing difficulties in the child, the social and personal functioning, and all this will cause distress to the child, to the parents, as well as the people in the community, which can impact the child's development, function, relationship, and so on. Okay, so I've highlighted here the behavior. Why? Because in children and adolescents, the cognitive and the emotional skills are still developing. Hence, the symptoms manifest mainly through behavior. So this lack of acquired skills as well leads them to having a lot of emotional dysregulation, which they express through behavior difficulties as well. So therefore, to understand more on the emotional and cognitive symptoms, we must first understand the behaviors. Okay, so let's go to the next one. So why children behave the way they do? So we believe that a child's behavior is an outward manifestation of how he or she thinks, feels, and perceives the world around them. Okay, it's a reflection of their inner stability and security. And it is through this lens that we have to understand their inner world. Okay, so what is the function of this behavior? It occurs because it serves as a function, right? And it produces an outcome. Okay, so it's essential that we take a step back, and attempt to understand the reason for the behavior, the perspective of the child, in order to understand their inner world. And according to the study that we found in 2020, a global prevalence of common mental health disorders in adolescents is 25%, so it's quite high. So we go to the types of behavior problems. We can classify it into two major domains of dysfunction. First is the externalizing behaviors, second is the internalizing behaviors. So what is the externalizing behaviors? Examples such as defiance, impulsivity. We can see some self-harm behavior nowadays. Uh, Defiance in the form of disobeying instructions, not following commands. Hyperactivity also is a form of an externalizing behavior. Aggression, stealing, lying, as well as sexual inhibition, which we can see in teenagers, right? And studies also show that childhood aggression is a strong predictor of adult crime and violence. Next is the internalizing behavior. So this is as the name implies, so the child will internalize the emotion, internalize behavior through social withdrawal. We can see depression here, anxiety, somatic complaints, and somatic complaints are very commonly seen in childhood and adolescence, where they present with the most common ones are headaches and stomach aches, okay, and also avoidance behaviors. Okay, so what are the factors that influence all of these behaviors? So first, we believe that every child is different, right? So each child has their own temperament. So temperament means a collection of innate psychophysiological characteristics which differs in every child. So I give an example, such as, when you see a baby, some babies are characterized as an easy baby, some baby they call it difficult babies. So what do you mean by this? So easy baby, for example, like they quickly adapt to routines, to new situations, they cry, but they very easily to be soothed. They remain calm. But difficult baby is babies who cry frequently, very difficult to soothe. So this is what we call as temperament of the child. So they are born like that. Okay. Having said that, no child is one way all the time. Okay. As they grow older, you can see difference or changes in the temperament. Next is the parenting styles. We see there are four types of parenting styles actually. So you can see that low levels of sensitive parenting and greater use of harsh discipline have been linked, according to studies, to the development of behavior problems. So the types of the negative parenting styles are such as authoritarian, neglect, and permissive. Okay, next will be the environmental causes. I will explain this a bit more after this. So this where you'll see a lot of difficulties in the family as a unit, communication problems, difficulty in the socioeconomic background, parent-child difficulties. I'll explain more about this. And also some children, yes, they will go through some adverse life events like loss of a parent, separation and abuse. So definitely this will be the main factors that influence emotional and behavioral difficulties. Next will be the psychiatric disorders. Definitely, children with psychiatric disorders definitely have behavior problems, um, and also neurodevelopmental disorders such as ADHD, attention deficit hyperactive disorder, autism, intellectual disabilities, which I will explain again later. Okay, so back to the environmental causes, which is the parent-child difficulties. I'll explain more about this. So these are the factors that influence a child's behavior. Mm, this is like the nurturing, the nature versus nature, right? So what we call by family disruption is like when some of the families they stay not just with the parents, but they also stay with the extended family. So this is where sometimes the parenting will be interfered with the other family members, and this can cause confusion in some of the parenting styles. Poor couple functioning is when we see marital discord, whether chronic or acute, causing negative effect on the parenting, definitely will affect the child as well. And parenting distress happens when one or both of the parents having psychosocial issues, like financial problem, things like that. Maternal psychopathology, the studies have shown that a parent, especially the mother, if mother is depressed or anxious, the child also is highly likely to have the risk of having depression and anxiety as well. Lack of social support, such as single parent family who is isolated, definitely will increase the chance of having behavior problems. Okay, so we see these are the common childhood mental health disorders. I'm sure a lot of you are familiar with this. So in the clinical settings, we see a lot of depression, social anxiety, panic disorder, generalized anxiety disorder, PTSD as well, post-traumatic stress disorder, as well as OCD. Yeah, we do see obsessive compulsive disorder in young children as well. Okay, so I'll just briefly explain a little bit. Um, for depression, this table depicts the differences in the presentation of depression according to the age. Okay, so these symptoms can all be present at any age, but are more common in the age group specified. So in adults, we know how, basically we know how depression is presented in adults, where they will present with low mood, right? Anhedonia means lack of pleasure, lack of affective reactivity, and all those symptoms. But in pre-pubertal children and adolescents, they mainly present with irritability, not so much as low mood. Okay, so this irritability, they will manifest through behavior problems. So they will have temper tantrums, they'll become very grumpy, hostile, not following instructions, very defiant, vengeful, and very angry. Yeah, so this is what we see a lot in children and adolescents. So you can see here also they will have somatic complaints. And also, for adolescents in school, they will have this extreme sensitivity to rejection. So we'll see a lot of peer relationship problems. Okay. Okay, so just a little bit on the scenario that we see during the COVID and after COVID. We find that there is an increase in the cases of depression and anxiety. So prior to the pandemic, rates of depression and anxiety among large youth cohorts were 11.6 and 12.9 percent respectively. But we see that during the first year of the pandemic, it has increased. Depression to 25% and anxiety to 20.5%. So these prevalence are found to be higher in studies collected later in the pandemic compared to during the pandemic, because and especially in girls, okay, and depressive symptoms were higher in the teenagers. So the factors that were identified to be positively correlated with a high prevalence of depression is mainly because of pervasive social isolation and missed milestones, and increased family stress, as well as decreased peer interactions. Whereas for the increase in the prevalence of anxiety is because of the uncontrollable worry, fear, hyperarousal, and the children having concerns for the health and well-being of the family, causing uncertainties and disruptions in their daily routines. So even in the clinical settings as well, later on, even after the pandemic, even after the restriction has been lifted and everything is already gone back to the norm, we still found the prevalence of anxiety and depression is very high. I also like to highlight that in the clinical setting, we also found a lot of the children and adolescents having social anxiety. We believe, although it's everything is back to the normal, because during the restrictions, their social skills have been halted, right? So hence going back to the society is highly anxiety inducing for them. They could not keep up with the family and societal expectations. So they present with school refusal. So we find a lot of school refusal even after the MCO has been lifted. So that were the common mental health disorders. We also deal with other behavioral disorders that are caused by the neurodevelopmental disorders such as ADHD, autism, intellectual disabilities, learning disabilities, as well as internet addiction. Okay, I'll just briefly explain on all of this. So ADHD, a little bit about ADHD. So it's a condition that makes it difficult for children to pay attention or control their behaviors. Okay, so I'm sharing some of the common misunderstandings that we deal in the clinical setting. Sometimes a lot of parents may feel that children are best in the mainstream medication, right? But then these children who are struggling were often undetected. So when detected, they're often dismissed. So sometimes the parents will say it will go away, it's still too early to say. Or of course, a lot of parents they tend to compare. I'm sure the child will pick up soon, like a brother or a sister. So these children they struggle a lot in school with academic performance because of their short attention span. They cannot do their work. It's not about the IQ. The IQ is normal, but it's just that they cannot pay attention, so they cannot complete the homework, cannot work on their own, uh, cannot work on their own. They need help and guidance consistently. So they always fail the exams, cannot perform consistently. If no reminders, they will not be seen doing their homework, okay, because they're simply just disorganized. Hence, they're often labeled as lazy and not interested in studying. So because of all these emotional difficulties, they also present with behavior problems. Sometimes they can be seen as having bad attitude. So due to the child having difficulty struggling with the education, they tend to gravitate towards pleasurable activities, such as all these disciplinary problems that we see in children in school. And often what is seen by the adults are just the behaviors. But remember, I said the behavior is a reflection of their inner stability of the emotions. So what is missed is the underlying core difficulty of the child. So hence, they easily labeled as naughty or delinquent. Okay, so that's for ADHD. For autism, we see a lot of aggression as well, and usually the aggression is usually as a result of a third variable rather than the autism itself, because they present with a wide range of disabilities. So these variables usually includes poor parental control because child with autism, they're very rigid, so they're very strict with their routine, right? So these behaviors often cause a great deal of difficulties for families, like hitting, kicking, and biting, and all of that. Even self-injurious behaviors causing um, parent stress. So they become easily aggressive when usually when adults interfere with their repetitive behavior or when someone tries to take away an item that they need to continue a repetitive routine or when they're trying to escape an uncomfortable sensory input. Do you remember sensory overload? For learning disabilities, this is mainly just for some specific domain, like language or speech, not as a whole. So this includes dyslexia or like dysgraphia. So about 20 to 50% of children with learning disabilities have behavior problems as well. And these include aggression, delinquency, excess consumption of activity. For example, now a lot of kids go using the gadgets and all that. So they have emotional problems as well. And due to these problems, they have issues with social behavior. So difficult to pick up social cues, which results in avoidance behavior. And in our clinical settings, like I see, we see a lot of children presenting with school refusal or truancy, and usually they often have these underlying learning disabilities. And when children present with learning disabilities, we also have to screen, whether they have comorbid ADHD or ASD as well. Um, okay, so this is intellectual disability. Um, this is characterized by significant limitations in both the intellectual functioning and adaptive behavior. So usually the IQ level is lower than normal. Okay, so the more severe the level of the ID, the higher the risk of coexisting psychiatric disorders. Usually they will have disruptive and conduct behaviors. They also have high incidence of depression and psychosis. And due to the experience of repeated failures, they develop negative self-image and low self-esteem. Okay. So in reality, all these children with these difficulties, they struggle at school, they struggle at home. At school, they struggle academically. At home, they struggle with their routines, they're very disorganized. So this shows disinterest in studies, unable to handle the stress and expectations from the society, from the parents especially. So they became uncooperative. So this is where the behavior problems start. Okay, and then they get depressed, they get anxious, angry, and aggressive. Okay, so the management, as I say, because they present with behavior problems, it's just the tip of the iceberg, right? So we have to address the underlying core. For all of the management of the childhood mental health disorders, usually it's individualized, but generally the treatment plan involves a combination of medications and psychotherapy. So in all of the patients, even from the first visit, we do parenting work, whereby we have to screen and treat the parents. Parenting skills such as teaching the parents to practice effective communication techniques. We do family therapy, we involve other family members as well. Definitely, we have to do individual work with the child, especially with the adolescent, if they have depression, anxiety. We also do have group therapy to enhance their social skills. And lastly, only we go to medications if needed. So according to the whatever disorders that they have. Okay, so we do give medications to treat the symptoms. So the challenges in the clinical settings, we find that adherence not it's not just a challenge for adult, but it's also a challenge for child and adolescents. Because of the management largely consists of working with the parents, hence the prognosis for the disorder also depends on the parental factors. So we did a systematic review, which was published last year, whereby we tried to assess parental factors that is associated with child or adolescent medication adherence. And from the studies, we find that the non-adherence rates varies very widely between 8 to 69%. But there are four main factors, four main parental factors that is associated with the medication adherence. Number one is the parents' socioeconomic background. So this is highly associated with low educational background of the parents, whereby families with low socioeconomic background may perceive the cost of mental health medication and treatment as an additional burden instead of a need. So always this poses a limitation to us clinicians and the clinical settings. So the next factors that we found to be associated is, of course, the parents' perception and attitude towards medication and treatment. Parents' attitude, we found that influence the child's attitude towards medication as well. Parents with lowered sense of impairment related to the child's symptom severity and the perception of own ability, meaning the parents felt they are self-sufficient and capable in dealing with the child's illness, which shows parental resiliency. So this is also causing a high risk of medication refusal. Okay, and stigma plays a huge role in psychiatric disorders. It always be the barrier for acceptance of medications, especially in families with presence of over involvement, disruption from other family members. So these are positively correlated with perceived consent medications. But in the clinical setting, sometimes we find that if we discuss with the parents and if we approve the parental request for drug holidays in some conditions, not in all conditions, this can also increase the adherence. Okay, so if we incorporate the drug holidays in the treatment planning progressively, this will demystify the stigma, so-called, and parents' negative behavior and attitude towards the treatment will be much better. So the third one will be the parents' history of psychiatric disorders. This definitely increases the risk of low adherence among their offspring, whereby parents with active psychopathology, with current psychiatric disorders, and also history of hospitalization shows high correlation with low adherence. This also we believe, is because of the effect that comes from the illness, not of the illness itself, meaning, parents with psychiatric disorders, they may feel overwhelmed, with having the responsibility of caring for a child with mental health disorders, right? And the last one is the family functioning or parenting styles, which reflects the family cohesion and the well-being of the family as a unit. So we find that the negative parenting styles, such as the chaotic parents, least affectionate and unable parents, increases the risk of non-adherence. So in conclusion, we believe that active participation for parents is crucial in management. So we have to adopt effective and positive parenting approaches, to facilitate the design of strategies to improve adherence in their children. And we also believe that education and awareness is needed to improve parental attitudes and perceptions towards medications, which we always do in, whenever we see the child patients. And also relapse prevention for parents with psychiatric disorders is important. The need to further investigate systemic or holistic intervention methods for families dealing with all these intergenerational psychiatric disorders. So that's all for me. Thank you so much for your kind attention.
Okay, thank you very much, Dr. Fatin, for the very informative presentation. So I think we still have probably one, well, I can allow one question. Yes. Any question from the audience? If not, I just ask one question to Dr. Fatin. How do we address issues of medication adherence in clinical setting with the parents?
Yes, Prof. Thank you for the question. So, as I mentioned, the management largely involves the parents. I'm sure my colleagues in pediatrics also agree with me when I say this. So we do a lot of parenting work even from the first visit itself. Parenting work means we screen the parents. If the parents is, dealing with issues, both of them or even one of them, or if the parents, let's say we find that is also struggling with mental health disorder, so definitely we have to treat them first before we treat the child. And so through that, we also try to gauge the family dynamics and try to understand the reason, the parental factors that I've explained before. So we try to find out what is the reason behind why they're not giving, the medications, whether it's because of the attitude or the stigma or other factors. So whatever factors that we find in the systematic review just now is actually resonate with what we find in our clinical settings as well. Yeah.
Thank you very much, Dr. Fatin. So, okay, there's one more question. Probably one. Is there any provision facility for parental counseling advice at the UMMC by Prof. Ng? Yeah.
Thank you, Prof, for the question. Yes, actually, we do have in our psychiatry, adolescent, and child unit. We provide group therapies and individual therapy for the child, as well as parent support group for the parents. Yes. So the psychiatrists work with the parents, as well as we have our occupational therapists conducting, and also clinical psychologists conducting the group therapy support group for the parents.
Okay, it's already past 9 o'clock, so I think we have come to the end of the session. So I'd like to thank the organizer and also all the speakers for all the excellent presentation, and of course to all the audience for your participation. So thank you very much, and I hope you have a good day and fruitful day, and bye bye. See you all again. Thank you very much.